everybody, and thanks to the Medtronic and the Parkinson's website for making this webinar possible. We are both, part of the movement disorders team in Sri Ramachandra Institute of Higher Education and Research. Dr. Vijayashankar is a fellowship-trained movement disorder specialist, and I am a neurosurgeon with special interest in functional neurosurgery. So this webinar is aimed more at the general public, probably the patients or caregivers of patients who suffer from conditions that may benefit from DBS. Now let's start at the start. What is DBS? DBS is deep brain stimulation. It is a pacemaker for the brain. Just like the cardiac pacemaker is in the chest and it sends in current into the heart, this pacemaker in the chest sends in impulses through these slender wires into the brain, into deep areas of the brain. Depending on which area of the brain the wires project into, the kind of diseases that it can help.
Shackles or a straitjacket to me. Not that there's so many things that have been taken away with it. I can't write. I can't eat by myself. I drink out, travel more. Little things that people just take for granted. That's the non-essential traveling gets out of the box and grabs you.
Mark's tremor is caused by irregular. He had to give up his job as a heating engineer. Mark wants to have surgery where doctors at the Walton will implant electrodes in his brain. They'll use a radical technique called deep brain stimulation. He'll be awake during the operation. Mark is about to have one of the most technically demanding operations performed at the Walton. Deep brain stimulation.
It's Mark with a C. Roberts.
Just to tell you about the stages of the operation, tomorrow will be stage 1, which will be with you asleep. Sticking about 5 screws on the top of the head and getting some scans for you, MRI and CT scans.
Okay.
So after the operation, we need to try and, you need to make sure that the screws don't come out.
Yeah.
On Wednesday, what we do is in the afternoon, take it out of theatre. So what we do is give you local anesthetic down there. So we'll numb the skin, but we'll be aware of whatever's happening.
Yeah.
And we'll go and put the electrodes down. All right?
Yeah. Yeah. I just want rid of it.
This has been a buzz of an exciting moment, knowing that, it's the big step to what it's been waiting for so long.
If another typical operation has about 10 or 15 different steps, this probably has 10 times the number of steps, and each step is very critical because we're trying to deliver an electrode into an area with dimensions in the millimeters. So every step is important, and every step, if it goes wrong, can wreck the whole operation.
Scalp to drill a hole through the skull, ready for the electrodes.
Is making sure that he's got the entry point and the target perfectly lined up.
Target. The team send different currents through the electrode to test what voltage is going to best control Mark's tremor.
Open close as fast as you can. Yeah, okay. Take your index finger and touch your tip of your nose and back as fast as you can. With this. Good.
So there, as you can see, the results can sometimes be pretty dramatic. So you can see on the operating table with the patient awake that the shakes that he had in his hands were immediately stopped by the electricity that is delivered in there. Now, we've tried to make this webinar a bit interactive instead of one person droning on all the time. So now let me put Dr. Vijay on the dock and basically ask him which are all the conditions for which DBS can be considered and where DBS can really help.
First, I would like to introduce myself. I'm Dr. Vijay. I'm a neurologist and a movement disorder specialist. I was straight from Toronto. Toronto, as you know, that Toronto is one of the best places for the world for movement disorders and DBS. So now, after joining with Vishnu and Ramachandra, we have started our movement disorder program, and our program is going to be the first, one of the state-of-the-art movement disorder program in Tamil Nadu. So our team is going to start another program probably after a COVID lockdown. So we are going to start the program. Good. So coming to the question, what are the conditions we do DBS? So the first and foremost is Parkinson's disease. So we do DBS for Parkinson's disease, dystonia, tremors, and there are several types of tremors and several types of dystonias are there. And we also do DBS for obsessive compulsive disorder, epilepsy, and also like anxiety, memory loss. So many conditions. You see this study, so it clearly shows that when compared to DBS versus the best medical therapy, this is one of the best studies all over the world they have done. Like almost like 300 patients they have done. So if you look at this one, overall, if you take a whole day, like the patients with DBS, they had improved like 4.5 hours of on time without troubling dyskinesia. So the patient had, like if you had like 5 to 6 hours of off period, the DBS improved the on time by 4.5 hours. And also it showed that the DBS, like 71% of the DBS patient had better than 32% of best treatment, whatever we say. So it is almost DBS showed 40% better than the best medical therapy. Like if you say that if you are on 5 tablets or 4 tablets or 4 different tablets, that's called as the best medical therapy. What is the best treatment what we have for Parkinson's disease today? And other thing is when to do the DBS. That's an important question we always have. So if you look at this thing, like within this is when we diagnose that the patient is having tremors, rigidity, or bradykinesia. This is the first 5 years. We can say that in the first 5 years, usually the patients like the medications itself is good enough to control their symptoms. After 5 to 10 years, they will start develop the fluctuations. So we need to increase the medication. When we increase the medication, obviously they will develop dyskinesia. After 10 years, the patient will have some dysphagia, like freezing of weight, balance problem, falls, postural weight, and everything will have. So, what is the best time to send a patient for DBS, or when to select the patient for DBS? It means the best time is 5 to 10 years. That's the best time for selecting a patient. But it depends upon every individual patient. So I'll show you the next thing. If you look at this cartoon, like 10 years back or 15 years back, we thought that DBS is the lost treatment, which is when the tablets are not all working. At that time only they advise DBS. So at that time, if you look at this one, the brown color is the motor symptoms like tremors, rigidity, or their slowness of activities. The blue one is the psychological condition, the overall Parkinson's overall well-being. So if you do a surgery around like a 10 years, something like that, so even though it gives benefits to the patient, but it improves the motor symptoms, but overall well-being and psychological condition is not improved. But if you do the surgery earlier, like around 5 to 7 years, something like that, so it improves the overall motor symptoms like tremors, rigidity, their slowness of activity, then overall their psychological condition and the overall well-being both are improved. That's why they have done a yearly STIM study. So in the yearly STIM study showed that we can do the DBS around when a patient is having 4 years of Parkinson's disease, and like when you increase this medication within 4 months of complications like off period, on period. So we can go for a DBS like 4 years or 4 months of complications. So the best candidates, who are the best candidates? Anybody who is having a Parkinson's disease, like tremors, rigidity, slowness of gait, freezing. The freezing which should respond to levodopa. But as you know, there are several other conditions like can mimic, or there are subtypes of Parkinson's disease like Parkinson's plus syndrome, or what we call as atypical Parkinson's disease, such as progressive supranuclear palsy, corticobasal syndrome, dementia of Lewy bodies. So these are all the subtype of Parkinson's disease. They may not respond well to levodopa. So whatever the Parkinson, we should first confirm whether it is a Parkinson's disease which responds well to levodopa, and they should have a good memory, because the condition which closely mimics Parkinson's disease, dementia of Lewy bodies, they will have lots of dementia. So that should not be there. And the secondary causes like drug-induced Parkinson's and other conditions should be ruled out. And the patient should have a fluctuations, like as I told you earlier, if a patient is having like off period for like cumulative off period, like 2 hours a day, like morning half an hour, afternoon half an hour, evening half an hour, night half an hour, total 2 hours, and troublesome dyskinesias for more than 1 hour, and age less than 70 years. But if a patient is good, or they are really fit and they are having no major problems, so in that case we can select patients up to 75 years. And there are some studies show that even like more than that also can be taken if the patient is really good and the patient doesn't have any problems. So age less than 70 years is one of the criteria, and the Parkinson's disease should be like 4 years of Parkinson's disease, and with good medication they have lots of on and off for within 4 months we can go for DBS.
So now, what is surgery? A typical neurosurgery is the patient is admitted, operated, and he goes home. But here, the process starts well before that. So after this detailed assessment, which Dr. Vijay has mentioned, he does a detailed charting of the patient, does a few tests, and then says, yes, this patient can be, beneficial for DBS. We admit the patient, and 1 day before the actual surgery, the surgery actually starts. So we do what is called a planning MRI. The planning MRI is a very detailed MRI. Some sequences are specific for the procedure, and then we prepare them for surgery. Now, this planning MRI CD or DVD is taken onto a planning station software, and we do a detailed planning on the computer about where to put the electrode. Typically for Parkinson's disease, the area that we put the electrode is someplace called the subthalamic nucleus, STN. On the day of surgery, we go through, as I already mentioned, the patient is fully awake. So we give local anesthesia and fit 4 screws on the head, and we fit what is called a stereotactic frame. Now the stereotactic frame is fitted and the patient goes for a CT scan. With this CT scan and the previously done MRI, both are fused together by the software, and then we know exactly in sub-millimetric accuracy where that subthalamic nucleus lies. So this is all the planning that is done on the computer system. The patient is again wheeled back after the scan to the OT, head is clean, patient is placed on the OP table. There is a transparent sheet whereby the surgery can happen in a sterile fashion behind on the head of the patient. And on this side, the anesthetist, Dr. Vijay, the neurologist, the electrophysiologist, and all can be standing. And we can communicate with the patient, make the patient do, move his hand, move his legs, speak, move his eyes, and things like that. So the stereotactic frame is assembled on the head. A hole is drilled on the skull on one side first, and then the opposite side. And then we fit in some sort of implements to ensure that the electrode once placed stays in that place. So it sort of holds the electrode. And now this is called a microelectrode recorder, where a slender electrode is passed in 2 or 3 electrodes at 1 millimeter apart, and which can record the electrical activity inside the brain from that area. All that is meticulously recorded. So we see at what stage we had the good recording, at what stage we had, and then we send in currents through those electrodes and find at what voltages we got good response, what side effects happened, and things like that. So it's a detailed assessment of the patient in the operating theater. And then we finally put the electrode. Now that blue line and the red line are the planning that we did before the operation. And that whitish streak that you see on both sides, that is the artifact that comes from the electrode tip. As you can see, the electrode is sitting exactly where we intended it to be post-operatively. Then, so that means that after the procedure, the patient goes for another scan. We confirm that everything is fine. There are no complications. There are no bleeding, nothing of that sort. And then we bring the patient back, remove all that what is fitted on the head, give the patient general anesthesia, and put the battery in the chest wall and connect that with cables, just like the Chennai metro tunnels that go under the road. We have a tunnel that through which the cables pass up to this point in the head, and then we close everything up. And this is a post-operative flow. So we keep them in the ICU for about a day, not more than that. The longer they stay in hospital, it is not good for them. There is a risk of infection and things like that. We shift them to the room. We may just do a basic check on the device. Usually do not turn on the device immediately. And then we tell them how to maintain. If it's a rechargeable device, we teach the family how to do the recharging and things like that, and aim to discharge the patient as early as 3 to 5 days from the operation. So this is essentially about what the surgery means.
So one more question I have. What was the result of the surgery? Or how beneficial is this? Or how will you say that what is the outcome of the surgery?
All right. So let me again share. In this particular type of operation, the result is quite evident during the operation itself. In that sense, it is a very rewarding operation, if one can say that. Here you can see that Dr. Vijay is doing the testing during the surgery, and I will also pop in briefly. You can see there is a bit of a shake in the patient's hand. Okay, and movement. Don't need to be a neurologist to know that this is a tremor. And as the energy is being increased, we can see that the movements are lot more certain, and the patient is able, the movements become more free. There is not much of tremor. And on the long term as well, there is good response. This is a gentleman who underwent DBS about a year or so ago. We've just temporarily turned off the battery, and you can see he's once the battery is off, he starts shaking. Battery is on, and you can see how dramatic the hand. So the
results of surgery, especially for symptoms of tremor, rigidity, that is tightness of the limbs, and the slowness of walking. The results are pretty good. Now, no amount about the possible complications as well. So, major bleeding, coma, restolitis, and things like that are in the order of less than 0.5%. Stimulation-related side effects are a unique side effect of this particular type of surgery. As I mentioned, there are electrodes placed in the brain. Depending on where the current spreads to, the side effects can happen. This is usually temporary. So we can change either the electrodes through which the current is passing. Usually there are 4 electrodes or 8 electrodes on one side of the brain. So we can change the electrode through which the current is passing or change some of the other stimulation parameters. Finally, infection is the most dreaded complication. Even if the patient has the wonderful post-operative improvement, unfortunately, if infection happens, the entire implant has to be thrown down into the bin. So therefore, that is something that is a two-way process. Both the treating team, patient and family both have to work together to minimize infection. That's about the results. We can also discuss a little bit. I think there are not many doctors on the attendees now, so I had brought a bit of technical information as well about the results. I will just show that briefly. So this is statistics. So this central line means anything that is in this side favors surgery and anything this side favors medical treatment. So for most parameters and most studies that have been done, international studies, surgery is definitely beneficial. This is shown in a much more easy to understand graphical chart that compared to medical therapy, where there is a 1% worsening, there is DBS. And the same thing as a chart that for most things like quality of life, which is very important. So one thing important to realize is DBS will not cure the Parkinson's disease, but helps to control it. Much like insulin will help to control the diabetes and not cure the diabetes. So improvement in the motor scores, which I had mentioned, improvements in the activities of daily living, improvements in some of the charting that Dr. Vijay would do, increased hours of good mobility and things like that do happen. And so there is, to say the final sentence, there is scientific evidence that surgery works. So I think at this point, I'd like to answer one of the anonymous attendees' question. Wrong placement of electrodes can also be a complication. I think it is the way I would like to answer that question is, if you had seen that initial video, what I was saying there, if a typical operation has about 10-15 steps, DBS has about 100 different steps. Each step can go wrong, and when it goes wrong, it can wreck the whole operation. Essentially, the electrodes can fall in the wrong location. The way to minimize that is to have checks and balances. One is a team that understands itself, a well-oiled, sort of machine, having the right protocol on the MRI, because in certain MRI machines, the SCN may not even be seen. Then we'll have to let the computer decide where the nucleus is. So therefore, there are many small things that are important, and everything adds up to a successful operation. The stereotactic frame that we use, if done properly, the error should be minimized to less than a millimeter. So you cannot totally be in the wrong place unless you make certain calculational errors and things like that, which are technical. Not that it has never happened. So therefore, at every step, there are checks. So the final check is the CT scan that is done after the procedure to check where the electrode is. And then making sure that we use all the gadgets and implements that are given along with the So there is something called a stim lock that Medtronic provides, and different companies have different things which help to keep the electrode in place. If we use all of this, then we sort of reduce the chance of things going wrong. And even if things go wrong, then we are able to identify it early, and before the patient wakes up from surgery, we are able to ensure that the electrode is in the right place. So that is the way I would answer that. And now